The largest factor, biggest factor that is stopping you from becoming a good, competent surgeon is your own fear, that scare factor. So, if you, and the same is true for any surgery, even when you start your open surgery, right? The first open surgery also, the same kind of fear you get, right? So, the same thing now you have to overcome again. Okay, so the only thing we have to fear is fear itself. Okay, there will be thousands of such quotes like this. So, 2, 3 I have selected. Okay, and everything you want is on the other side of fears. So, once you overcome this, you will automatically become a good laparoscopic surgeon, and you won't even realize it that you have already done it. Okay. So, as a very popular saying that even impossible says I am possible, right? Okay, so 10 years back, my senior used to tell me every time I used to be on the table with him. This is not from the internet, this is my own, not mine. My senior used to tell me always, Rakesh, accidents always happen on the highways because it's a common tendency with the assistant. Say, I'm the assistant, you are the chief surgeon, right? So you insert the camera, you see the organ of your interest, that is the target organ, be it uterus, be it kidney, be it gallbladder, and it looks easy. The first look, oh, it's a piece of cake, it's very, very easy. Then my senior always used to tell me, the road that appears the easiest, the maximum chances of accidents are there. So never take it easy, right? So you have to be rather more cautious on the highways. You have to drive more cautiously, right? Because the first look, your mind gets the training that means the reflex, the signal that surgeon is taking it easy. You will increase your speed. You will neglect small safety points, the safety tips, right? So then the chances of injuries increase. Okay, so simple definition, all of you know it. Any minimal access surgery or laparoscopic surgery, it's a union of modern technology and surgical innovation that aims to accomplish surgical therapeutic goals with minimal somatic means physical and psychological trauma. Okay, now the difference is, as I told you, most of it is repetition. For the surgeon, for the patient, there is a huge list, less pain, less scar and early recovery, everything. But for the surgeon, what are the major differences? The first one is the benefit for the surgeon, the magnified view, right? So that helps a surgeon, right? So allows the precise dissection. Now the others are like altered tactile response, you know it. It's a two-dimensional view, okay. You're not having the correct assessment of the depth. Okay, and usually longer operating time. So getting fatigue, tiredness, irritability of not completing it timely. So all those factors come into play, right? And you have to develop entirely different operating skills, operating technique, and adaptation of the same principles which till now you've been applying to open surgeries. Now you have to adopt them to this newer technique, that is laparoscopic surgery. Okay, this is the crux of the story for becoming a good laparoscopic surgeon, right? You have to be comprehensive. It's not just about knowing the correct technique, right? Suppose you know how to perform a surgery, but 10 minutes before the surgery, you come to know that your assistant fell sick and is not able to come. So, will you abandon the surgery? No, right? So, you need to find the alternative the replacement for the assistant. Now assistant might not be trained, right? Because it's not it's a makeshift arrangement. So now you have to perform the surgery. So now you have to divide your mind. Okay, you have to focus on the surgery simultaneously. You have to keep instructing the assistant also that show me this, show me that, take in this direction, give me this instrument. So you have to be like knowing everything, right? Suppose some say uh, carbon dioxide, the surgery gets too long. It ran for 2.5 hours, and the technician did not check how much CO2 was left in the cylinder. It gets finished midway. So what you will do? What is the way out? Open is the easiest thing. That's the last thing. Anything you can think of? Yes, the senior guys. Nitrous. Okay. Yes, but you need the everything, na? The tubing. Okay, you can use the same tubing, but the attachments and everything may not be there because the cylinder attachments are different. Right? You might be having nitrous cylinder, but if you don't have the attachment, you have to attach it to the CO2 insufflator. Lift the abdomen. That I have never thought of, but yes, yeah, very, very valid point. Something I have used myself twice in my lifetime, one in India, one abroad also. Right? That has happened with me twice in my life till now. It's very simple. You used it yesterday only in the pig air. Right? But there is one disadvantage with the air. You cannot use current. Right? So if you think that whatever surgery is left, you can manage without a significant amount of diathermy, then you can proceed with air, right? Even if your insufflator is not working, you can simply connect with the nebulizer and insufflate the room air, right? It won't be the same controlled way of giving the volume and the pressure, but somehow if say just 15 minutes surgery is left, so you can just manage with these. So I have done it twice, both luckily during cholecystectomy, which is easier to manage, right, even with air. So you should know the alternative way out also, right? So everything. So this is the crux, as I told you, knowing the anatomy, knowing the physiology, knowing the correct instruments, the equipment, right? How to use it, everything. Okay, the ergonomics we talked in details, the correct ergonomics of laparoscopic surgery, the indications, that means you have to be selective in taking up the patients for laparoscopic surgery, the contraindications, right? That is more important to know. And the complications, as I've been discussing in last 2-3 days, it's not just theoretically knowing the complications. There is much more than that when talk about laparoscopic surgery, right? You should be able to identify the complication on table itself, right? And if it is a life-threatening one, then there is no alternative way out. You have to manage it then and there only. Otherwise, you will lose the patient, right? But there are some complications which you cannot handle at that point of time, but you can buy some time, 24 hours, 48 hours. So you can just come out, close the abdomen, and then reoperate the patient in the next sitting when you have the proper expertise, equipment, everything available, right? So this is the basic thing about the laparoscopic. Now, a few related points. I think ergonomics we talked in details, right? And trocar insertion we talked about. Where is needle? I told you how to hold it, what direction, and the safety measures related to it. How to check the correct position. What is the point of entry? What are the alternative points? So everything we discussed before. Okay, now the setting of the equipment and the ports. This is very simple, the straight line principle. The monitor ideally should be right in front of the surgeon's eye, right? So at one end, the surgeon is standing, in between is the target point. The target point, the target organ, I mean to say, and the surgeon, in this case it is appendix. So target organ, the surgeon and the monitor, the 3 points should form a straight line, right? Your neck should be straight. It should not be like you are seeing the monitor like this, because you will get this spasm and then uh, things can happen. So this is the correct way, right? Endotrainer itself, like you're doing. So right in front.
But this is low.
Yeah. Now we'll talk about the positioning. Now this is again very, very important, not to get tired during the surgery. So what all points you need to look for in this? Okay, so first of all, when you're standing, okay, your elbows, okay, the height from the surface to my elbow, okay, so it should be either at level or below it. It should not be above the elbow, like say this is the elbow height, so my elbows should be either below or at the same level, should not be above. So it is around say 80% of the elbow height. Table should be arranged at the waist level. Then the hands, your angle of the elbow should not be less than 90. It should be either perpendicular, forming a 90-degree angle, or slightly below, pointing downwards, working like this. This is or this, not this. Okay? And shoulders should be in a stable, it should not be like this or this, right? Or this, right? Short surgeons, they do not get the footsteps, so they are operating like this. Okay? So you should not uh, attempt these stunts in the theater. Now the ideal distance between the eyes and the monitor should be 60 centimeter, can be more or less, should not be less, can be little more, but that's the ideal one. And it should be right at the eye level or slightly below is allowed, but not above it. Okay, so at the level or slightly below is acceptable, but not above the eye level. So these are the points you need to know about this. Okay, so same thing. So waistline table, gaze down view of the monitor is allowed, either straight or gaze down. Straight line principle, triangulation we talked about. Straight head in the axis of the trunk without rotation, so neck should not rotate, it should be straight. Shoulders in a relaxed and neutral position, as I have told you. Elbows bent to 70 to 90 degrees, should not be bent more than that. Forearm should be either horizontal or gazing down, descending down position. And hands pronated, so that's the resting position for the forearms. Okay, if you keep it pronated for long, you will get tired, you will get, even in the shoulder, you will get the spasm. Hands and fingers lightly grip the handles and the handpiece. Okay, so avoid competing for the same space. Okay, so that's a very common saying. The dueling swords phenomena, scissoring effect that you should avoid when working inside, and working against the camera and blind spots is strictly prohibited. Okay, uh, the surgeon and the camera should be looking in the at the same spot, right? Suppose you are working, operating the gallbladder, right? The camera is slightly gone towards the midline, towards the stomach, towards the left lobe, but the view is not proper. Ideally, the operating area should be in the center of the screen. It should not be in the corners, right? Whenever your assistant is showing you the operating area in the corner, stop and then ask it to position it properly. It should always be in the center so that you know the surrounding tissues, the oriented to the surrounding organs. That is to minimize the chances of injury. And don't work in the blind spots. That means you should not work if the light is not adequate. Okay. Now the trocar entry, I think most of the points we discussed, just 2-3 points more. No obstacle between the trocar entry and the target. This also I told you that you should select the trocar entry very carefully. That patient, say if you are using intra-umbilical trocar entry, so you should rule out there is no umbilical hernia, and you should rule out there are no expected intraperitoneal adhesions, either because of previous surgery or because of some inflammatory pathology in developing countries, maybe because of tuberculosis or peritonitis, because of other reasons. Okay. And avoid this, I have just told you, avoid areas of prior surgery because of adhesions. Right? And thinking will not overcome fear, but the action will. So I think these 2-3 weeks you have done a lot of thinking, some action here, but the action that matters is on the patient, on your patient, on the table. Okay? So, and I think that is it.